Okay, so let's talk about Meniere's disease. Not totally understood disease, but quite important disease if you are talking about the inner ear. So when we are talking about Meniere disease, we are talking about, let's a little bit talk about the anatomy. So we start with anatomy. The important thing about Meniere disease is to know how the cochlea looks, or the idea of the cochlea, with the endolymph in the center and the perilymph and the semicircular canals and the utricle and the saccule, the inner ear. Now, not only this, but also the cochlear aqueduct or the cochlear duct, where the endolymphatic sac, it ends with the endolymphatic sac. You need to understand that the endolymph should be reabsorbed in the endolymph sac, and the amount of endolymph should remain in a constant amount and not too much, because if there is too much, there is what is called endolymph hydrops, and this is thought to be the underlying mechanism of Meniere. So you can ask what caused these endolymph hydrops, namely too much endolymph. And the cause is not entirely known. It is thought, for example, that an insult like a viral or bacterial infection caused a problem with reabsorption of endolymph. This can cause the endolymph to accumulate, what is called endolymph hydrops, and the pathologies that comes as a result. It is thought, for example, that the accumulation of endolymph can rupture the membrane that are between the endolymph and perilymph, those two fluids in the inner ear. They should be uh, divided by a membrane, um, and this membrane can rupture when too much endolymph is accumulated, and when it is ruptured, the endolymph and perilymph can get together. Now remember that endolymph is high with potassium and perilymph is low in potassium, so this uh, endolymph and perilymph coming together can cause disturbance in electrolytes that should be in the perilymph and endolymph, and as a result, the symptoms that we are going to talk about of Meniere's disease: vertigo, tinnitus, fluctuating hearing loss, and uh, our fullness. Those are the main four manifestations of Meniere disease. And there is also a theory that the accumulation of endolymph not about rupturing the membranes, but it just compressing the organs of the vestibule, and this is how it can cause its symptoms, the attacks of Meniere. Now, when we are talking about Meniere attacks, again, as the name suggests, it's attacks of Meniere, and those attacks usually are between 20 minutes, not less, 20 minutes to 12, 24 hours. Usually, this is the time frame for attack. This is the time frame from diagnosis. So, Meniere disease is a recurrent and worsening disease of attacks, usually between 20 to 12, 24 hours, of vertigo, tinnitus, that is usually like a low roaring, hearing loss, that is usually in the low frequencies, and our fullness. They feel like fullness in the ear. So the diagnosis is mainly clinical. There is what is called probable Meniere and definite Meniere. Now the difference between the two is the audiogram. In probable Meniere, there are only the clinical manifestation, at least two attacks that are very similar to how Meniere looks like: vertigo, attacks of 20 to 12, 24 hours of vertigo, tinnitus, and our fullness. But in probable Meniere, there is no what is called documentation of audiometry, with low frequency hearing loss, which is the most common which is the most common manifestation of Meniere, in audiogram. Now remember that there is another criteria for diagnosing Meniere, that there is no other disease that explain the symptoms of the patient. So you can't diagnose Meniere if, I don't know, vestibular schwannoma or vestibular neuritis or BPPV or I don't know, suprasemicircular canal dehiscence, that Touliot phenomena can be in both. You cannot diagnose Meniere when you have another explanation for the manifestation of the vertigo of the patient, for example. No. And this also talks about differential diagnosis for Meniere's disease. So probable and definite Meniere, again, the symptoms, no other explanation, time frame is needed, and the difference between definite and probable is the audiogram with low frequency sensory neural hearing loss. This is not very common to see low frequency sensory neural hearing loss, but in Meniere it happens, and this is quite helping to diagnose the disease. Now, in the sense of progression, this is a progressive disease, namely it becomes worse and worse with time. The hearing is becoming more severe with time. So this is a progressive disease, but it comes usually in attacks of Meniere. Attacks, namely the patient can be okay between attacks, the test may be normal, but in attacks you expect to see again the attack, vertigo, tinnitus, and everything. The attacks between 20 minutes to 24 hours. And if you do the tests in the attack, you would expect to see hearing loss that is more severe in the attack, for example. Now, there are clues in some tests for Meniere's disease. If it's progressed, so it can cause caloric test abnormalities like weakness in the ear. It can cause in electrocochleography a ratio between summing potential and action potential that is more than 0.5. Sometimes in CVAMP you can see high frequency, that 1000 frequencies, that is higher in interamplitude than what you see in CVAMP in 500 Hz. Those are some clues from vestibular tests, and of course you may see vestibular weakness in the side of the Meniere disease, for example, I don't know, in VHE test. There is also directional prepondence that sometimes can be seen in Meniere, which is part of the results for the caloric test. So you see that there are some hints, but the main thing about Meniere is that this is a clinical diagnosis and audiometry for a low frequency hearing loss for definite diagnosis of Meniere, or for definite Meniere. When again there are the symptoms, no other explanation, audiometry that is low frequency hearing loss, recurrent attacks, progression with time. This is the Meniere. Sometimes an isolating insult event, for example, viral bacterial infection, but it doesn't have to be, because not all the time we know the explanation to the reason for this endolymph accumulation, for the endolymph heat drops. And we talked about pathogenesis, rupture of membranes, or compression because of the accumulation of endolymph in the inner ear. And about the treatment, usually the treatment starts with more conservative treatment with low salt diet, some drugs that can reduce the amount of fluids, so hydrochlorothiazide or acetazolamide. And if it doesn't work, there are more aggressive therapies. For example, drainage of the endolymphatic sac. We said that the endolymphatic sac is responsible for reabsorption of the endolymph. So if it doesn't work okay, it may not absorb the endolymph as it should, and the endolymph will accumulate. Why would it not work as it should? Again, because viral, bacterial, or an idiopathic cause, it may be an insult event that may cause these problems to arise. So the treatment starts with this conservative treatment, low salt diet, diuretics, osmotics, and those are the first conservative treatments. Now, when those fail, there are more aggressive treatment. There are endolymphatic sac drainage, as we said. There is a ablation of the cochlea, for example, with intratympanic gentamicin administration. Steroids, I don't want to talk about them, okay? And labyrinthectomy or vestibulocochlear nerve cutting, let's call it. Those are the more surgical invasive procedure that can be used for Meniere disease. What else can I say about Meniere's disease? This is a very known disease, so very good to know this disease. Okay, so Meniere disease, insult event or idiopathic, cause of endolymphatic heat drops, endolymph accumulates because of the insult event, or rupture of membrane between the endolymph and perilymph, or compression that cause the symptoms of Meniere, usually attacks of vertigo, hearing loss, tinnitus, and usually the attack is between 20 minutes minimum to 24 hours, 12 hours. Sorry if I'm not strict on the time, but at least 20 minutes. This is right. And this is a recurrent disease, progressive disease. Those attacks comes and go, and diagnosis is based on clinical. It can be probable or definite if there are the symptoms, no other explanations, and definite by audiometry that cause sensorineural hearing loss in the low frequency, which is quite unique for sensorineural hearing loss, because sensorineural hearing loss is more commonly a cause for a high frequency hearing loss. Now remember, no other explanation, no other thing that we can think about that can cause those symptoms. No vestibular schwannoma, no vestibular neuritis, no BBBV, no suprasemicircular circular canal dehiscence, no I don't know what, autosclerosis, ossicular chain dislocation, or ossicular chain discontinuity, I don't know what, tympanic membrane rupture, cerumen impaction, otitis externa, otitis media, whatever you can think about that may even cause the attacks. Now, of course, otitis media usually is not vertigo, tinnitus, hearing loss that is sensorineural, because it usually otitis media cause conductive hearing loss, and sensorineural hearing loss in the low frequency because it usually causes conductive hearing loss. So you can understand that otitis media is not really looks like it, and our fullness for Meniere. But think about differential diagnosis for this because the patient is with you. So this is about Meniere disease, its manifestation, its pathophysiology, diagnosis, probable, definitive, and the treatment that starts with conservative, low salt diet, Uramox, Diamox, diuretics, then the more invasive procedures, ablation, labyrinthectomy, cutting the nerve. So there are endolymphatic sac drainage. There are invasive procedures if the conservative treatment fails. Again, it's usually a more progressive disease with recurrent attacks. And this is it about Meniere disease. Thank you very much. If there are any mistakes or correction, please tell me. Write in the comments below, and this is it. Thank you very much.